giving you a 10-minute rundown on prostate cancer survivorship. I've got no disclosures. So I think at this point in the program, almost all of us here are either urologists or in support of urology patients. So we know and understand the burden of prostate cancer and making the diagnosis and getting these patients on treatment. US incidence is roughly 112 per 100,000, about 225,000 new cases annually in the US, with a worldwide burden of 1.5 million new cases. Fortunately for our patients, most of these cases are localized at the time of diagnosis, and the US prevalence is estimated at nearly 4 million, so that's a lot of prostate cancer survivors that are out there, a lot of opportunities for improved care. In spite of all of our best efforts, it still remains the second most common cause of cancer mortality in US men. So here we see an AI-generated image about, the term was prostate cancer diagnosis. And I think as urologists or in support of urology patients, we do a pretty good job of having this talk with patients. I spent 4 years as a general urologist, but it was one of the more tougher clinic consultations that I used to have, because you really want to thoroughly inform the patient on the treatment options that are available out there. As surgeons, we're very good at explaining the surgical process and the recovery. And then, but also as surgeons, we know and understand that not all of these patients are going to be surgical candidates, either because of their disease burden or their comorbidities. It's important to discuss immediate and long-term potential consequences. This is kind of highlighted by some decisional regret studies that do favor radiotherapy and active surveillance over surgery in the short term. But those of us that see these patients long-term know that radiotherapy will eventually lead to equivalent sexual dysfunction rates and then potentially devastating urinary adverse events. So honest discussion of anticipated risks and consequences is key. Here's an AI-generated image of a prostate cancer survivor. Though we know that they don't always look this happy, right? The survivorship journey begins right after the index cancer treatment ends. And really the focus is on physical, emotional, and functional state of the patient. During this time, we monitor them for recurrence. And it's important to manage adverse treatment effects, which we know happen. This is a time where I try not to blame the treatment or the individual. I think the best term that I learned from Drew Peterson is we're helping them manage the unfortunate consequences of life-saving treatment with the overarching goal of improving quality of life. Fortunately, we don't have to do this alone. I mean, medicine is a team sport. Different models are out there depending on the practice setting. At a comprehensive cancer center, we do a pretty good job of taking care of these patients, with the survivorship care plan being kind of the roadmap for this. The survivorship care plan will have important information about the diagnosis and staging of the patient's disease, can give a rundown of treatment details, provide surveillance recommendations, and should offer information on post-treatment symptoms and adverse effects or adverse events to include resources for seeking additional care. Ideally, in a perfect world, this results in coordinated care between the physicians, the APPs, mental health providers, and social workers, as well as the patient caregivers, with the patient being at the very center of this, this framework, right? So as functional and reconstructive urologists, we want to provide evidence-based survivorship interventions. One of the things that brings patients to the door right away after they have their prostate cancer treated is sexual dysfunction, and we know that this comes in different flavors, with erectile dysfunction being the most common thing that these patients will talk about. But that isn't the only thing that's going on as they recover from either the prostatectomy or the radiation therapy. There are changes to the penis, whether it's changes to length or girth. Some of these patients will go on to develop Peyronie's disease as well as ejaculatory or orgasmic dysfunction. We know that there aren't uniform penile rehabilitation strategies, but we know that patients do benefit from aggressive, vacuum erectile devices or traction in conjunction with pharmacologic interventions. And in my opinion, this is the best opportunity to get the patients to buy in on their recovery, right? You get them to, you talk about smoking cessation, you talk about improved diet, exercise, and weight loss. So this is the best opportunity to capture these patients. We know that urinary incontinence happens. That's more apparent immediately after the prostatectomy, with 50 to 70% of patients reporting some degree of incontinence. Fortunately, most of these patients will recover incontinence within a year of treatment, and we know that pelvic floor rehabilitation can accelerate the return to continence. But the long-term prevalence is somewhere between 10 to 20%, and untreated incontinence leads to a decrease in physical and social activity, isolation, and withdrawal. So it's important to talk about surgical treatments because we know that they're highly effective, and we should engage these patients in shared decision-making and helping them pick whatever treatment's going to be the best for them. We do a thorough evaluation, a combination of patient-reported outcomes, objective measures such as pad counts, pad weights, and then in the office we undertake urodynamics. In my practice, under select circumstances, most important for me is a cystoscopy to rule out strictures, anastomotic stenoses or bladder contractures, urethral compression, as well as any potential consequences of prior incontinence therapies. So as functional reconstructive urologists, we deal with a little bit of everything, right? We embrace the good. We want to take care of the good. I mean, who doesn't love a good primary sling or unradiated PROACT or a good AUS surgery? We're equipped to deal with the bad. That's multiple revision surgeries, the fragile urethra, whether it's a consequence of subcuff atrophy or prior urethroplasty or prior AUS erosion. And then certainly the incontinent patient that has both incontinence and a bladder neck contracture or an anastomotic stenosis. Those are challenging patients to deal with. And we dread the ugly, but sometimes we're the last line of defense in dealing with the ugly. That's the failed incontinence surgery, the devastated outlet that we heard about yesterday, patients with urinary tract fistulae or contracted bladders or upper tract deterioration, secondary to stricture. So how good of a job are we doing in providing comprehensive survivorship care? This group is a collaboration between NYU and UCSF. They looked at claims-based data, patients that are insured and should otherwise have good access to survivorship care. And overall, in spite of a pretty high rate of urinary adverse events at 33%, the treatment rate was pretty low. And if you dissect this table here, I mean, a treatment is just about anything really, to include cystoscopy or catheterization, et cetera. But in spite of urinary incontinence rates ranging kind of in the 11 to 12%, only about 1 to 1.5% of patients eventually did have surgery for the incontinence. And Black patients fared worse, so perhaps there are some opportunities as well for culturally competent care. So in summary, prostate cancer survivorship is a journey, a lot of potential for detours. Survivorship care plans aim to provide a streamlined roadmap. And as functional and reconstructive urologists, we're uniquely qualified to definitively treat most of these conditions that impact the survivor population. So thank you.